Greetings. I'd like to now consider some process innovations using some of the lenses that we've considered. They are cooling matters, variance Hertz, psychology matters, and utilization matters. Let me just put those down and here, just as a reminder. So we're going to do cooling, utilization, variance Hertz, and then the psychology piece. So this one here is all about cooling, and I want to recap what we've got going on in this simulation briefly. So there are two tracks of ORs shown here. I'm just going to slide this over a little bit. Tracks A and B, and then track A is this one up here, and B is down here. And there's two ORs. And currently, in the base case, these two ORs are located in this pool, and they are used by one surgeon and one anesthesiologist. And the same setup is true for track B. So, looking at the options here for pooling, we could talk about pooling the anesthesiology pros. I'm not sure that's going to fly. For the same reason that you're probably not going to be able to pull the surgeon because there is a consult prior to going into surgery, prior to the day of surgery. The surgeon will be familiar with your case, would have developed a relationship and could have been multiple visits, even office visits. And so you really don't want to randomly assign a surgeon. That's just not going to fly. So I don't think we can pool the anesthesiologists or the surgeons. If that's not true, I'm happy to be educated. But the one I'm going to look at is, what happens if we pool the ORs instead of put them into a common pool of 4 ORs, and surgeons can access any available OR. The first, if there is one available, they don't have to wait for one in a track of 2. Now they can, get access to all 4. Will that make a difference to performance? Is what we're looking at here. Okay, to implement this, we can do it fairly simply. What I'm going to do is I'm going to just go in here and make this 4. And so the pool is going to be essentially this operating room pool A. We're going to ignore operating room pool B. And when we grab an OR from, for, the old track B, we're going to grab it from A, not B. And we also need to release it back to A when we release the OR here. So it's good. So essentially, all of the OR requests are coming out of operating room pool A. There is just one type of resource unit here, and that is operating room. So it doesn't matter. They were split into tracks A and B, or allocated to tracks A and B, but now we're just lumping them together. And again, surgeons can access any of the 4. And that should be enough to estimate performance. Now, the problem with this case study is that we've got a 570-minute day, and there's a substantial warm-up. The patients are entering the system cold, so the surgeons are not operating probably in the first half hour of the day. And then you've got this idea that you're going to warm it, you're going to cool it down as you get toward 5 o'clock. And so if there's a chance you're not going to finish the surgery by 5, you will deny that last patient access to the surgery and bump them to the next day, and with all the attendant drama and dissatisfaction. So what we're also going to see when we run this model is that the flow times increase through the day. So let's go ahead and see what I mean by that. So the first patient, encounters an empty system, does pretty well because they run right into registration and go to sedation and whatnot, and there's nobody in front of them. But the next patient experiences delays behind the first patient. The third patient, has to wait for both, possibly even for the first one, but certainly for the second. And so things get, more and more backed up as the day goes on. So I want to run this out 570 minutes. That's the duration of the workday again. I'm going to just run it to completion. Okay, so I have an error here. Let's just debug this. I have not set something up correctly here, so let's just make sure when I do seize, I should be seizing operating room pool A, and I should be releasing operating room A. See, I set that up as anesthesia, so it has to be operating room. My bad. Okay, let's just run that again. So I was grabbing and seizing and releasing the resource, and I pointed the release to the wrong type of pool. Okay, so I've got that in red. Let's run this to completion. So I'm getting 5 completions in, what was formerly track A, and then 5 in B. And notice how this goes. I mean, the first patient, probably this is the first patient, is doing, something about 105 minutes. And then, as we go through the day, it blows up to 140, 40-minute difference there, possibly. The average is 125, which seems a lot better than what we had, but I can see down here I didn't do so well. And these are statistically similar. So the fact that I'm getting such wildly different results, it means that I have to do quite a number of runs here. Maybe 5 is enough to get an estimate of these means and to be able to adjudicate whether, in fact, this pooling of the ORs is actually better than the base case situation. Theory tells us it should be. Let's just see what else we have here. So the utilization on these, on this group of 4 ORs is 74%. That's some sort of recent time estimate, maybe the end of the simulation. Through the day, it's 63% utilized. The surgeons are in red, so clearly they are the bottlenecks. And but that said, it's still possible that I got better results. I got 5 and 5. And the question is, how close I am to actually getting that 6th to complete. That 6th person, that's the 6th patient, is according to the simulation, I started surgery but not completed it. Okay, let's do one more simulation run just to get a feel for this case. Now, to change to get a new run, we need to just reset our random number generators, and we can do that by changing the seed value just to any other value. Let's take a 7, and we just run it again. So I'm recommending that you do this, given what I'm seeing here, a minimum of 5 times, and make sure that you go to 570 minutes each time, so that we're simulating the day. Okay, and then I'm going to run this, and you can see the difference. I was at 125, now I'm at 147. This one dropped from the 150s down to 144. Initial times are about 2 hours and 10, and then it blows all the way up to 3 hours. So that's why multiple runs are needed. And the surgeons that picture is still the same, and the operating room is through the day 65% utilized. But this does include the warm-up period where the OR cannot be busy because the first patient hasn't progressed that far. Okay, so that is the pooling idea. You're going to build a table, document your confidence interval or your means at the very least for the base case, now for this pooling case, and then we'll consider additional innovations in the remaining clips.